In discussions, the brachiocephalic vein approach is performed with in-plane imaging, which typically permits real-time observation of needle penetration into the vein. So procedure is easy for unexperienced patients. Intraoperative complications tend to occur more frequently in infants, and so patient selection should be considered depending on the levels of patients. In conclusion, procedure can be safely performed even by junior residency. For reducing the complications, patients should be selected carefully based on the experiences of physicians. Thank you for your attention.
I'm John from Taiwan. I have two questions. The one is, this is a tunnel or non-tunnel catheter, because we can show you the puncture site above the shoulder. The second question is, all of the complication case is by the senior resident. How to prevent it?
If
you mean the yeah. Yeah. Tunnel? Not, yeah. Yes. Tunnel side is subclavicular area. Yes. Yeah. And the second question is
There are
yeah. Yeah.
So the senior resident
preventable. The senior resident performing patients is more smaller cases. It's difficult to puncture the sentences placing the catheter. The reason of the complication.
Kevin Koguchi from Houston. I was just wondering why you would choose this approach rather than an internal jugular vein approach.
Conventionally, we choose internal jugular vein by the anesthesiologist, but my colleagues go to the French the surgeon do the supraclavicular insertion, so more safely he learned the patient. So we introduced him. We compared the two procedures. In our institution, the supraclavicular is easy to insertion for more unexperienced surgeon that I introduced.
Thank you. We'll go to the next talk. Thank you very much. Next talk is Ramesh Nataraja, Dietetic Practice.
Good morning. My name is Angus. I was one of the investigators on this project. I'm presenting on dietetic factors for the acquisition of laparoscopic skills, a randomized controlled trial. So laparoscopic simulation using bench trainers involves replicating laparoscopic surgery without actual patients. However, with a typical setup of one student per simulator, this requires significant time and resources. Dietetic practice, in which two learners work together, alternating between actively practicing and observing, could be a potential solution to improve training efficiency. Twice the number of students can therefore be trained using the same time and resources. Collaborative learning theory suggests that dietetic practice may be an effective teaching method, particularly for novice students. However, there is very limited evidence for dietetic practice in laparoscopic simulation. So we therefore aim to determine the effectiveness of dietetic practice compared to individual practice for novices learning laparoscopic skills, and our secondary aim was to identify their attitudes towards the learning experience of dietetic practice. So we conducted a randomized control trial comparing individual and dyadic practice in laparoscopic simulation. We recruited 80 novice medical students with 40 randomized to each group. Both groups completed a 90-minute laparoscopic simulation workshop, with the individual group practicing alone and the dyad group practicing in pairs, alternating between practicing and observing. We assessed the participants at 3 stages: before the course, immediately after the course, and 8 weeks after the course. As our assessment, we used the double glove model, which is a validated quantitative scoring method, and the participants also completed a questionnaire and small group interview after the workshop to determine their attitudes towards the learning experience. We analysed the data by comparing the scores between the 2 groups using unpaired t-tests. We analysed the trends within each group using analysis of variance in paired t-tests, and we analysed the qualitative data using thematic analysis. So moving to our results, 35 individual group participants and 31 dyad group participants completed all assessments and were included in our final analysis. Whilst the dyad group participated in the workshop in pairs, the assessments were all completed individually, and an odd number attended the final assessment. So this is why there's an odd number in the dyad group. For the double glove scores, this graph shows the mean scores for the dyad and individual group at each assessment stage. And as we can see, there was no significant difference between the dyad and individual groups at all 3 assessments. So this suggests that dyadic and individual practice were equivalent. We also analysed the trends within each group, and we found a significant overall difference in the mean scores of the 3 assessments within each group. So we used paired t-tests to then determine where those differences arose. So both groups improved significantly after the workshop, indicating that it was effective at teaching laparoscopic skills. For the dyad group, there was no significant difference between the post-course and retention test scores, but there was a significant difference between the pre-course and retention test scores. So for the dyad group, this indicates that they effectively retained their skills 8 weeks after the workshop. For the individual group, there was a significant difference between the post-course and retention test scores, but no significant difference between the pre-course and retention test scores. So in contrast to the dyad group, the individual group actually reverted to their baseline level and were not able to maintain their skills 8 weeks after the workshop. In terms of the learning experience, we divided the themes into the advantages and disadvantages of both workshops. The advantages of dyadic practice were peer support, peer feedback, and observation time, and the disadvantages were reduced practical time, issues with feedback, issues with teamwork, and insufficient faculty feedback. For the individual group, the major advantages were extended practical time, independence and task understanding, and personalised faculty feedback, and the major disadvantages were a lack of peer support and feedback, and the limitations of continuous practice. So in conclusion, we found that dyadic practice is non-inferior to individual practice for novices learning laparoscopic skills, and dyadic practice is therefore a potential solution to improve training efficiency. We also found that dyadic practice may also lead to superior long-term skill retention. In terms of the learning experience, we found that dyadic practice was an acceptable alternative to individual training, and that novices practicing in dyads described a positive learning experience. So these findings contribute to the growing evidence for the effectiveness of dyadic practice in simulation-based education to improve training efficiency. Thank you.
Any questions from the floor? I have a question. Why would the dyad practice group have less faculty feedback?
It's simply because there's twice the number of students in the room, and there's only one faculty member there to supervise everyone. So you're not able to receive as much personalised faculty feedback from the supervisor.
Right, because you also mentioned that they have less time to practice, so 2 of them are using the same time slot as a single person.
Yes, so the pair uses the same amount of time as one individual, so they each have half the amount of time to actually practice themselves.
And which was the question?
Hi, good morning. Great presentation. Rob Ignacio from the US. I'm still trying to understand the dyadic practice. I know they get less time on the simulator, but were they encouraged to work together afterwards to maintain their retention? Because I'm trying to understand why they had better retention despite after the exercise.
Yeah. So the workshop was the same for both groups. It was just that the dyad group alternated between practicing and observing, but there was no working together after the workshop. I think there are several reasons why there may have been superior retention, and it could be attributed to peer feedback, observation, or like a reduced cognitive load from sharing the burden of collaboration. But we'd have to investigate that further to find the exact reason why.
Thank you very much.
The next talk is Improving Confidence to Perform Laparoscopic Hepatojejunostomy in Inexperienced Young Surgeons during a short-term pediatric endosurgery workshop by Dr. Volkata.
Thank you, Jonathan. So as you know, the laparoscopic hepatojejunostomy, LAP-HJ, is a complex procedure, especially for the pediatric surgeon without prior experience of LAP-HJ. And especially the vertical needle driving and no time required for LAP-HJ is one of the most difficult procedures in the pediatric surgery and endoscopic surgery. However, limited access to appropriate program and handle training opportunity present the barriers for us. So in this study, we evaluated the impact of our short-term high-intensity workshop in enhancing the technical skills and the confidence of experienced young pediatric surgeon performing the LAP-HJ procedure. So I'd like to outline our two-day workshop structure. So it consists of the mini lecture of the surgical basic skills and the training in basic skill of the vertical needle driving, knot tying, and training of LAP-HJ using this kind of the disease-specific simulator, and laparoscopic cholecystojejunostomy, mimicking the LAP-HJ with using the pig model. And all participants have objective evaluation test before and after this workshop. So for the skill evaluation and training, we use following the two instruments for the basic skill of the vertical needle driving and the time LAP meaning, which can objectively evaluate its suture skill and its accuracy. And in addition, for the laparoscopic HJ procedure, we use this kind of the disease-specific simulator. So 8 pediatric surgeons with no previous experience in the LAP-HJ completed the workshop, and the average postgraduate yield was 8.9, and the gender ratio is 5:3. And half of the participants already have over the 500 cases of endosurgery procedure. So this is our finding, and concerning our basic skill evaluation, only full layer closure score was improved. And regarding the advanced skill evaluation, the needle insertion accuracy of fast suture and confidence in this advanced skill were improved. So concerning about these data, the workshop did not show the significant skill improvement, and the participant, most of the participants was found to already have acquired basic skill to a degree. However, the LAP-HJ technique, we found that the notable improvement in the fast needle insertion accuracy was observed. And this improvement may be related to that the surgeons who are previously unexperienced with the rapid HA technique gaining the confidence from the workshop. So there are some limitations, such as a small sample size and the pathway response bias in self-rated confidence. Therefore, we need a future study, including the larger cohort with the control groups and the longer follow-up period. And in conclusion, our specialized endoscopic surgery workshop proved to be an effective tool for inexperienced surgeons to gain the confidence in advanced techniques, even after the short training period. Thank you.
Dr. Ayush Vic here. Dr. Akiko Yokoi is going to talk about an efficient interview of involved personnel.
Very pleased to be here to discuss patient safety culture. And nothing to declare. Just culture is a safe and fair organizational culture which balances accountability for failure and learn from it. Just culture approach focus on system improvement and individual behaviors. We present a case of medical accident highlighted in interview and discuss just culture. A patient suddenly experienced cardiac arrest immediately after intubation for surgery and passed away 6 weeks later. Investigation was conducted following institutional policy. Right after the event, the countermeasure subcommittee was established aiming to analyze cause, seek liability, and deal with malpractice lawsuits. The initial interview with the physician went normally. Since the patient had severe comorbidity, several departments were involved in this event. They convened with countermeasure committee members to review the event. The physician eventually found it challenging to convey their thoughts, perspectives, since everybody else judged them. Then the physician was called by the subcommittee in the president's office. Due to steep power dynamics, the physician felt helpless in communication their opinions. After a patient's death, the in-hospital medical accident investigation committee was established per Japanese law. Although the law emphasized that the committee should not pursue individual responsibility, this committee had a role in determining where the responsibility lies. Although external members were included in this investigation committee, the physician didn't have opportunity to describe their opinions directly to the external members. In the final formal report, although it is clearly stated it's not intended to pursue individual responsibility, the particular individual act were emphasized to contribute to the outcome. The hospital apologized to the public for taking accountability for admitting malpractice, and consequently, this case developed into a criminal case. Is this organization particularly awful for the physician? Some may say yes, but reviewing this case, we found that it's not an issue linked to this organization. OECD survey showed that although governance approach trends toward learning over accountability, healthcare worker perspective, more than half feels that their organization is not non-punitive. Adams and Vincent, who creates the London Protocol, also pointed out that the organization tends to blame individuals when something goes wrong. After survey report also quoted that a surgeon's opinion that there is a bad outcome, the surgeon typically gets the blame. Medical accident investigation guidelines show that individual perspective is very important for system improvement, and interview environment is crucial for the individual to feel safe conveying their opinions. Just culture approach, depending on behaviors shown here. Individuals who make mistake or human error feel distracted and depressed, so they need to be consoled and support, and the system has to be changed. When the individual don't know the risk of potential risks, then they should be coached. Behaviors only intentional, then disciplinary action should be considered. In conclusion, a gap between governance approach and individual perspective still remains regarding non-punitive culture. Fair investigation process should be essential for system improvement. The concept of just culture should be understood and implemented for fostering patient safety culture. Thank you very much.
Thank you. Are there any questions from the floor?
More a comment, I guess, but I'll ask it with a question. Are these procedures in your hospital privileged legally? In other words, they cannot be discovered by a court of law and used in their...
Yeah, I agree, totally agree with you, but it's very thing, so that we have to learn how to sorry, and then we can find some way to establish patient safety culture. So this type of organization, we thought that M conference also very difficult sometimes. Yeah, but I totally agree with you.
Thank you very much. For the sake of time, we'll go to the next call.
In Indonesia National Tertiary Hospital.
Good morning. Thank you. I'm Setra from Cipto Mangunkusumo Hospital, Indonesia. I would like to share about our effort to reduce adverse events during surgical neonatal transfer process. Neonates, especially those who need surgical procedures, are among the most vulnerable patient groups towards iatrogenic events due to their size, priority, unique psychological development, and inability to verbal communication and sensitivity towards environmental stressors. 80% of adverse events in neonates preoperatively happen due to circumstances during the process and duration of a transfer. Those events included hypothermia, desaturation, unstable hemodynamic status, etc. Our hospital, Cipto Mangunkusumo Hospital, consists of 8 main buildings in almost 120,000 meters square. In that regard, one of the approaches to reduce and prevent adverse events is to optimize the patient transfer process. In this study, we were using specifically designed neonatal transfer form. The study was a single-center trial in one of Indonesian tertiary hospitals. The neonates who underwent either emergency or elective surgery in the operating theater or procedural room outside the neonatology unit were included in the study, while the patients underwent bedside procedure surgery or transferred from the delivery room and non-surgical units with ASA status 5 or with HFO ventilation were excluded as samples. Subjects for this study were acquired using consecutive sampling, and randomization was performed at the beginning of the study. 58 subjects were allocated into 2 groups, and the specifically designed neonatal transfer form used in this study were adapted from the Boston Children's Hospital transfer form at the right sides, while the general patient transfer form at the left side is the institution transfer form used for children and also adults for all in-hospital transfer purposes, including patient transfer between wards to radiology department, operating theater, etc. From the result, there is no significant difference between the subjects' characteristics in both groups, and more than 40% of subjects in both groups were classified as premature. Following subject characteristics, this study analyzed adverse events during both preoperative and postoperative transfer, irrespective of the subject, taking into account if one subject has more than one event. Adverse events are lower in the intervention group, 18/58, than in the control group, 25/56, both during preoperative and postoperative transfers. However, the difference is not statistically significant. There were 43 adverse events from a total of 114 transfers, and both mortality cases came from the control group and were not during the transfer process. Event incidence in our center was 37.7%, which is higher than in the other study. In a sample, the study conducted by Delecretes et al., it was 25%. And another study by Saula et al. Found that there is a statistically significant difference in adverse events between the intervention group and control group, which was introduced to a structured SOP for newborn transfer. And the key difference, which is also a limitation in our study, is they perform training for the health workers before applying the new SOP. For conclusion, adverse events in the intervention group are lower than in the control group, despite not being statistically significant. And this study gives valuable data for baseline information and may become the basis information for establishing standard procedure and operations that prioritize patient safety, especially in similar centers. Thank you.
Question?
Good morning, everyone. I am Shebun Zhang. I come from West China Hospital of Sun University. I would like to share my work, secure ligation and puncture-induced sepsis impairs hepatic vitamin A mobilization with you. Decreased serum VA levels were found in septic children in our previous study. However, the effect of sepsis on serum VA levels was unclear. We researched the effect of sepsis on VA levels in serum and liver in mouse model of sepsis induced by COP. HPLC was used for analyzing serum retinol levels. LC mask was used for analyzing was used for quantifying retinol and retinal partimeter levels in liver. We also explored the underlying mechanism of decreased serum levels in COP mice through RNA sequencing. We found that serum retinol levels and hepatic retinol levels were significantly reduced in COP mice. However, hepatic retinol palmimetic levels were not significantly reduced in COP mice, which suggested that when mobilization from liver was disturbed by COP-induced sepsis. Transcriptional expression of genes involved in vein mobilization from liver was downregulated in COP mice, which revealed a hypodynamic state of hepatic VA mobilization. Genes encoding for retinal ester hydrolysis and the specific transporter of retinol were significantly downregulated in COP mice. IHC also revealed a downregulation of proteins involved in VA mobilization. So in concluding, COP-induced sepsis impairs hepatic vitamin A mobilization and leads to a decrease of serum vitamin A level. Thank you.
Thank you. Are there any questions from the floor?
Good morning, everyone. I am Dr. Sarita from India. I am going to present my work on difficult airway in surgical children, approach and outcome, my experience. So, airway management and endotracheal intubation in pediatric patients, especially in neonates, is normally a difficult task due to their different anatomy, but it becomes more difficult in the patients who are having complicated anatomy due to their diseases. Difficulties may be in the form of face mask ventilation, laryngoscopy, supraglottic airway uses, tracheal intubation, and sometimes extubation also. The incidence of a difficult airway is 4.7% and the mask ventilation is 1 to 6%. My aim of study is to highlight our approach for the management of difficult airway in the children who are going for the surgical indications. My study period was 6 years. I have included 52 patients with the age group of from the neonate up to 12 years, and the male-female ratio was 3:1. We have included all these patients who were having difficult airway like tracheal stenosis, hydrocephalus, large cystic hygroma of neck, encephalocele, oral mass, and TMJ ankylosis. These are the patients which we have included in my study: hydrocephalus, cystic hygroma, nasal encephalocele, occipital encephalocele, and bilateral cystic hygroma. So, materials and method, when you are suspecting the difficulties in the airway, you have to prepare your cart with all the adequate equipments like mask and different sizes of the endotracheal tube, different sizes of the laryngoscopes, blades, airways, laryngeal airways, etc. After the pre-anesthetic checkup, consent and proper communication with the parents was done about the complication and side effects of the difficult airway. Patients were taken in OT and attached with the monitors. After the proper position and of the patient, we were pre-oxygenated the patients with adequate size of the mask. We have preferred the awake intubation with the help of the inhalational agent. After confirming the feasibility of face mask ventilation, we have administered neuromuscular blocking agents in some patients. And we have introduced the adequate size of the endotracheal tube according to the age and the weight of the patients. My observation and result is that we have included total 52 patients of different difficult airways. Out of 52 patients, we have done successful intubation in 44 patients, approximately in first or sometimes in 2 or 3rd attempts. But we have failed in 10 patients. Among 10 patients, the 3 patients were died during post-operative period due to the complications of the airway, difficult airway, and 7 patients were postponed for the next time with the planned surgery. The 7 patients were postponed for the next time after the tracheostomy of that patients. So, conclusion: pediatric patients are different from adult in weight, size, psychology, physiology, and anatomy. So, every physician should be very important, should take in this very important. And in anticipated difficult intubation, you should have all adequate instrument of adequate sizes. Direct laryngoscopy and face mask ventilation is the key point. It is very important management skill for managing the difficult airway. Without anticipated difficult airway management is really a very challenging, because these patients looks apparently very normal, and sometimes they having tracheal stenosis or laryngeal stenosis, and sometimes they also require urgent tracheostomy, cricothyroidotomy or jet ventilation to save the patient's life rather than taking multiple attempts to intubate the patients. Confirming the feasibility of face mask ventilation before administering the neuromuscular agent is recommended. Thank you.
Open for comments or questions?
I want to work with you. High serum albumin level was associated with AKI in critically ill children in PICU. There were studies that revealed high serum albumin levels were associated with developmental AKI. However, the detailed association between albumin levels and AKI has not been studied in critically ill children. So the aim of this study was to estimate the detailed association between albumin levels in AKI in critically ill children. Children admitted to 4 PICUs in China were all screened for enrollment. Children discharged from PICUs with uncertain outcomes, those without documented albumin values, and those older than 18 years old were excluded. AKI was defined according with KDIGO clinical practice guideline, restricted cubic spline curves based on large distribution models were generated to evaluate the detailed associations between the levels of serum albumin and the PICU mortality. So, in total of 8,499 children were included. The mean age of the children was 2.7 years. 40% of children developed AKI in total. And the detailed association between serum albumin levels and the risk of mortality was shown in Figure 1. The risk of AKI increased with increasing serum albumin levels in children with serum albumin above 40.1 gram per liter. So in concluding, high serum albumin was associated with AKI in critically ill children in PICU. Thank you very much.
Thank you. Question on the floor?
So typically these patients start with a high albumin to begin with. What are the patient populations who have these high albumin?
Adults, the high albumin levels was associated with AKI, so I wanted to check it in children.
The question was why? Why do your children have high levels of albumin?
The possible explanation is dehydration. Because I analyzed the data and I found that the shock index was higher in patients with high cerebral albumin levels.
I think they were falsely high, not really high. Were they checked after rehydration?
Actually, I haven't analyzed the data.
I think the time high albumin level or some doctor just give albumin to the very sick baby, therefore the serum albumin levels will be elevated. I think that's the scenario because you have patient with severe illness with low urine output, you may want to use albumin, and then.
The albumin was measured on a machine, and the AKI was defined according to clinical guidelines. It was identified by using albumin. I'm sorry, I'm not totally understand what you mean. Could you please?
We can talk after that. Thank you very much.
Oh, thank you.
Who else is not here? Number 11? No? Okay, we'll move on. Number 12 is pediatric surgery service during 3 years after COVID-19 pandemic, experience from a provincial referral hospital in Indonesia by Dr. Alamoy.
Good morning, everyone. Thank you for your introduction. My name is Patricia from Pajajaran University, Bandung, Indonesia. There's nothing to discuss here in this research. As we know, since March 2020, COVID strikes worldwide, and its impact was very large, and it's affecting all aspects in our lives. And we who work in pediatric surgery field also experience many changes. This study shows the changes in pediatric surgery services in our center, Hasan Sadikin Hospital, Bandung, Indonesia. We collected data from a year before pandemic and 3 years after until February 2023. And as you can see, the patient number was fall after pandemic and have not been recovered since its normal nature. From the distribution, we can see that the outpatient number has not recovered back after 3 years of pandemic. In our institution, the modified regulation in outpatient department and increased utilization of telemedicine affected the number of patients visit in our outpatient number. And due to pandemic, improvement healthcare system, especially in the referral system, were made. And so we can see after the pandemic, the emergency patient was lower and then got stable. And the emergency operation is in line with the patient. Interestingly, we can see that the number of elective surgeries in our department is increasing every year, even exceeded the number before pandemic in the 3rd year. It is because since the outpatient service are getting back to its usual, we are catching up to serve elective patients that have been postponed during the pandemic by adding an additional operating room and increasing the number of our surgery daily. And if we look more details, this is the graphic that shows the dynamics for the month. Outpatient clinic was most affected every time there is epidemiological wave or hospital service restriction. And meanwhile, the emergency patient declines after March 20, but its flow is stable even there is epidemiological wave and internal hospital services restriction. Then the number of emergency operation decreases in the 1st year and became stable after. Although there was 48.3% decrease of elective surgery in the 1st year of the pandemic, it is slowly increasing and every year, and in 3rd year it exceeded by 17%. And the wave also affected elective surgery, especially on the 2nd wave. And if we look further of the type of cases, interestingly, we can see that the percentage of urogenital surgeries were higher, and it's because the additional operating room were mainly used for the hypospadia cases. And in terms of neonatal surgeries, as described in other publication, it is not much disturbed because most of neonatal surgery cases are emergency and urgent, so it can take the same delays as others. And if we look the numbers of pediatric surgery patients with concomitant COVID-19 waves, the incidence was only 0.3%, but the mortality is quite high, is about 10%. And the patient who needs surgery must then protocol designed for a COVID patient and underwent surgery in a different zone. But the team who treated the COVID and non-COVID patient were the same team. An elective patient who also underwent additional swab screening a day before the procedure, and this procedure caused delay in 3% of elective patients. So the conclusion is the pandemic of COVID-19 has made changes in pediatric surgery services in many ways, and it's increasing morbidity and mortality of the complicated patient, but some improvement in referral system and operating room utilization have been benefiting pediatric surgery centers in our institution. Thank you for your attention.
Open for questions or comments? What do you think is the biggest thing your hospital learned by managing elective surgery through the pandemic?
Since elective surgery was open, we are getting an additional operating room, but the additional operating room was a bit smaller than the major, so we can do more of urogenital cases like hypospadia cases.
Okay, thank you.
Coming to the last talk of the session, Dr. Sinu Tai. The association between SARS-CoV-2 vaccination and lymphatic malformation exacerbation among pediatric patients. A case series.
I'm presenting a case series of exacerbation of lymphatic malformation after SARS-CoV-2 vaccination in pediatric patients. So as lymphadenopathy being one of the most frequently reported adverse effects after SARS-CoV-2 vaccination, research has been looking at vascular malformation-specific adverse effect after vaccination. And the report has found an incident rate at around 60% and an increased risk with the diagnosis of triple Trenaunay and Parkes-Weber syndrome. Since Taiwan has only been starting vaccinating pediatric patients from September 2021, the potential adverse effect among pediatric patients are yet to be discovered. So, using electronic health records, we included patients that visited the clinic of a pediatric surgeon at National Taiwan University Hospital from September 2021 to December 2022 due to an acute exacerbation of pre-existing LM after SARS-CoV-2 vaccination. And we identified 7 patients, 1 male, 6 female, with a median age of 8 years old that had an acute exacerbation. All but 1 patient received BNT. Looking back at their initial presentations at LM diagnosis, 3 had retroperitoneal LM, and the remaining 4 had LM at visible sites, 1 on chest wall and 3 around head and neck. All of our patients fall into the category of complicated multicystic form LM, and 2 was histologically proven to have lymphatical cavernous LM. And regarding the treatment they received at the initial presentation was individualized based on the location, size, functions, and aesthetics considerations. However, regardless of the treatment received, all patients were able to achieve their treatment goal, which is decrease in size and symptoms alleviation. And looking at their acute exacerbations after vaccination, all patients reported pain, enlargement, and worsening of previous symptoms. 2 reported additional fever, and their intervals between vaccination and symptom onset ranged from 3 days to 3 months. Looking at the treatment, 2 patients received observations without no medication prescribed, while the remaining 5 received antibiotics with or without NSAIDs. 3 resolved under the treatment, and the remaining 2 required additional treatments including steroids, excisions, beta blockers, and or mTOR inhibitors. The treatment length ranged from 7 days to 87 days. So in total, 4 of our patients were hospitalized and 3 could be treated as outpatients. And none of the patients were admitted to an intensive care unit, and all of the patients were able to return to their baseline after treatment. So looking at the photo on the left is a patient at acute exacerbation at 1 month after vaccination, and the photo on the right is the same patient after 35 days after treatment at clinic follow-up. So we can imagine if the size of an LM is located near airway, then it could be potentially life-threatening. So in conclusion, SARS-CoV-2 vaccination may be associated with exacerbation of pre-existing LM. And in our study, we identified, the patients that we identified had complicated form of LM and were at younger age. We hypothesized that these populations may be at increased risk, although we do understand that this is only a single center and single surgeon study. And empirical infection control with symptomatic treatment could usually return the patients to their baseline prior to vaccination. However, extra caution should be taken when vaccinating patients with LM at near airway that could lead to potential compression. So these information may help physicians inform and advise patients regarding the risk of receiving SARS-CoV vaccination, especially among specific population, for example, like patients that had LM with complicated form or at younger age. Thank you, and I'm happy to take any questions.
How during pandemic, because they were put in the bottom of the pile, and now you are seeing them and then you're attributing that to the vaccine.
Pardon?
Once the pandemic is over, we are seeing the complications of the actual disease and we are blaming it on the vaccine.
I think this could also be one possibility. However, like we try to ask the patients regarding like their symptoms. However, they only reported, that they started to have those symptoms that's very specific to like obvious enlargement in the lymphatic malformation, and the patients that we included in our study reported those symptoms after like vaccination. It's hard to establish the association. However, we do see like a time. We do see that it's after vaccination.
Because we didn't see this in anywhere else in the world.
Yeah, I think like maybe further study would be required as well. Yes.
Thank you.
Along those same lines, for this case vaccine, there's a whole bunch of kids with lymphatic malformations. I'm trying to understand too, is this just coincidental? It's only 7 patients, and I think that's what everyone's trying to wonder.
Yes, behind this. However, there isn't a lot of like research doing this, but we do see some like overlap between the pathophysiology of lymphatic malformation and some pathophysiology with SARS-CoV-2 vaccination adverse effect, or like the SARS-CoV-2 infection itself. So including like the VEGF pathway, VEGF-C pathway, it's involved in lymphatic malformation pathophysiology, and we also see that in SARS-CoV-2 infected patients. And also like there is an increase interleukin 6, 8, and TNF factors in the LM patients. Like research has found that those increase in those cytokines level in LM patients, like the lesion site. And we do also have like research done regarding the mRNA vaccine because of the transmembrane spike protein that they use. Research has also shown that after mRNA vaccination, there are increase in those interleukins. And however, we cannot ascertain that this is the pathophysiology behind that, but we do find that there are certain like mechanisms that's in common.
I'm Fujino from Tokyo. Thank you very much for presenting your study. I have one question. Did you see any difference between the types of the lymphatic malformation in macrocystic and microcystic? Did you see any difference?
Yes, thank you for the question. I think this is a very important question. However, in our study, we only identified, through the process, we only identified patients with microcystic, multi-microcystic form of LM, or patients with lymphatical cavernous LM, but we do not have patients with like simple cystic LM or other kind of LM, so we cannot do the further analysis, but since that we only identified those patients in our study and our populations have a younger age, we hypothesized that it's possible that patients that have complicated from LN or like patients at younger age may be at increased risk. However, we do not have maybe perhaps further data would be required to ensure to know further results.
Thank you very much.
Thank you.
One question. Phase 2.
Yes.
What vaccine do the children get in Taiwan?
So in our study, one received Moderna. However, it was because the patient was 20 years old, so it still belongs to the pediatric population. But for most patients that is pediatric in Taiwan, most of them received BNT.
All right, very good. Thank you for a wonderful session.
Position without increasing the rate of metastenosis. Interestingly, the extended urethral plate incision, or LOP, up to the gland tip has not been popular to date. So the aim of our study is to present our experience with the modified tip technique with an extended urethral plate incision up to the gland tip. We review the medical records of all children with hypospadias undergoing our modified tip repair at our center from July 2016 to October 2022. Our indications for the modified tip repair, all cases of distant hypospadias, regardless of the width, the depth of the urethral plate, and for cases of proximal hypospadias without severe penile curvature. All operation was performed by the same surgeon, and the data were prospectively collected. Our modified tip technique, extending the midline urethral plate incision up to the glass tip, and creation of urethra with running simple suture PDS 60 with two intermediate layers. The first one consists of paraurethral spongiosum tissue, and the second one is a buttonhole transfer dorsal flap. Single layer vertical mattress suture for closing the gland's wings, and urethral catheter in place for 7 to 10 days. Regular postoperative meatal calibration and selective urethral dilation. And the results, we have totally 108 patients, among them 88 with distant hypospadias and 100 with proximal hypospadias. The operative time from 70 minutes to 90 minutes. And the median hospital stay is about 9 days, with a follow-up, mean follow-up 41 months. Early complications occur in totally nearly 13%. Among them, urethral fistula is 6.4%. Gland dehiscence in the 0.5%. You see the complication in early complication is more in proximal hypospadias. And the late complication, the urethral fistula rate is 5.9% for all patients, 0% for distant hypospadias, and 11% for proximal hypospadias. We have meatal stenosis only in 0.5%, 0 in distant hypospadias, and 1% for proximal hypospadias. Meatal regression is 3.2% in all, and recur or persistent curvature in 2.1%. Here you can see immediately after the operation, you can see our neomeatus is brought up to the tip of the gland as a natural location, and this after long-term result, after operation, is lit like and the proper anatomical position of the meatus. So as you know, Socrates emphasized that the midline ureteral plate incision in tip should be limited to the ureteral plate and not carried into the rim of the glands at the distant margin of the plate. And following this principle, average metal stenosis rate of a standard tip technique for distant hypospheres was reported in a systematic review and meta-analysis recent in 2015 is about 3.6%, range from nearly 2 to 7%. And for proximal hypospheres is about 4.4%. And in our series, the rate of metastenosis was only 0.5%. So the results of this study show that the AUPI up to the glass tip did not increase the rate of metastenosis comparing to standard tip technique. Historical studies have shown that there is no evidence that the subepithelial tissue at the glands is different from subepithelial tissue at the ureteral plate. Therefore, the cause of complication of metastenosis could be other technical factor, rather the extension of ureteral plate incision. And we recommend routine metal calibration and selective ureteral dilation, as is very useful. Not incising the ureteral plate to the glands tip make the new metal opening lower than the natural position of metal opening. Our experience show that incising the ureteral plate to the glands tip could help bring the new metal opening to the anatomically correct position, similar to some previous reports. So in conclusion, ladies and gentlemen, our modified tip technique with extended ureteral incision up to the glands tip is safe with a very low incidence of metastenosis. With this modification, the ureteral manometers can be created in a nearly natural location at the glands tip with a seed-like shape. However, further comparative studies may be needed to confirm the result of this study compared to the standard tip technique. So thank you. I'm happy to take any question.
That how deep you are giving incision when you are dividing the circulate, number one. And second is that when you are giving the incision right up to the tip of the glands, what I personally feel is associated with more of stenosis rather than normal looking meters. So comment on this please.
So thank you. To the rim of the glands tip is about 2 or 3 millimeters only. And our depth of midline ureteral plate incision is depend on the size of ureteral plate. It's enough to cover to make a new urethra surrounding a stent, let's say 8 French. So usually the depth of the incision is about 2 millimeters.
No, how deep you are going? You are involving the epidermis, dermis, or full thickness of the urethral plate.
Full thickness, yeah.
So that lead to the post-operative stenosis or stricture formation.
This is theoretically, but in practice, we prove that this not cause stenosis because still there is a thin tissue of epithelium. So I think with the stent in place and the scar is cannot form to stenos, the meatus.
So many literature coming on this tip.
So we have the follow-up of mean follow-up of more than 3 years, 41 months, and 188 patients, and just one stenosis. I think this is with some information of the glands like a balanitis. So I think that's why I present here. Our fear of stenosis is only theoretically. Practice show that maybe stenosis can be caused by other factors. You can see in my results.
Thank you.
Thank you.
Congratulations, Dr. Song, for the fantastic results.
Ladies and gentlemen, we present a novel technique of advancement of ureteral insertion in surgical repair of piloureteral junction obstruction due to high ureteral insertion. As you know, high ureteral insertion or HUI is one of the causes of piloureteral junction or PUJ obstruction. Surgical repair for this anomaly mainly pyeloplasty with many options, classified into two groups. Dismember pyeloplasty is most popular dismember Anderson Hine techniques, and non-dismember pyeloplasty like a Fenner pyeloplasty or Foley, YV pyeloplasty, and etc. The techniques for advancement of PUJ alone rarely reported. Here we present a novel technique of advancement of retinal insertion without dismembering the pyelo-retinal junction in surgical repair for PUJ due to high retinal insertion. This is a case report. A 5-year-old boy suffered from multiple episodes of abdominal pain. Ultrasound show anterior posterior diameter of the left renal pelvis of 43 millimeters. Renal scintigraphy, left kidney without that obstruction, with the stent preserve function of 43%, the split function. And this is a CT scan. You can see the suggested high retinal insertion with severe hydronephrosis. So our surgical technique, here you can see in this picture is our technique. So the first step is you can find the intraoperatively high retinal insertion causing kinking of this junction, and this cause obstruction. And firstly, the outlook, we see that is almost normal caliber diameter of the junction. So firstly, we make a transversal incision in the upper part of the renal pelvis up to the junction. After that, we insert a catheter to be sure that there is no intrinsic obstruction of the PUJ. After excluding any intrinsic obstruction, then we decided to make advancement of the pyelo-retinal junction only. So from transversal incision of the pelvis in the upper pelvis, we make periapical suture of this pelvis without cutting anything. So from transversal, like Heineken-Mikulich, we make a periapical suture. So it's advanced the retinal insertion down, but still there is excess of lower half of pelvis, lower to the retinal insertion. So the second point, now we make a transversal wedge resection of excision of the lower half of the pelvis, and then we make a transversal suture to close the pelvis. So I think, so you can see in the picture, after two maneuvers, the first one, transversal cutting and periapical suturing of the upper pelvis, and wedge resection of lower half of pelvis, the pyelo-retinal junction is now transferred, advanced to the most dependent position, as like in the final picture. So the operative duration was 75 minutes. The patient recovered uneventfully. We put, anyway, for sure, we put a PUJ stent externally. And the drain was removed on the 6th operative day. And the boy was discharged the next day. At a follow-up of 36 months, he was asymptomatic. Ultrasound showed pelvic diameter is only 10 millimeters, and the renal scintigraphy showed no obstruction. So as you know, most popular surgical repair for PUJ is Anderson Hine pyeloplasty. Anderson Hine pyeloplasty is technically demanding procedure requiring dismembering of PUJ and pyelo-retinal anastomosis, and the complication rate after this procedure is reported to be around 10% for open surgery and about 11% for MIS or minimally invasive technique. With failure of surgery is about 4 to 5% in recent systematic review and meta-analysis. So other techniques for non-dismembering pyeloplasty also involve directly POJ, and therefore with the risk of leakage or stenosis. An option for repair POJ obstruction due to high ureteral insertion without associating intrinsic obstruction is just advancement of POJ to the proper most dependent position. And only one technique reported to the advancement of this POJ alone was reported by Palmer in 2005. But he transect this POJ and make a low anastomosis, make a new anastomosis in lower position. And thus also dismembering and have this, kinking or leak. Our technique is simple without dismembering of anastomosis, thus minimizing the risk of complication. But the important thing is to not associating intrinsic obstruction. And this technique could be feasible for both open and, I think, laparoscopic approach. So in conclusions, ladies and gentlemen, this novel technique of advancement ureteral insertion without dismembering of POJ can be a good alternative option in a surgical repair for POJ obstruction due to high ureteral insertion without intrinsic obstruction. So thank you for your attention.
Yama from Osaka. Thank you for a nice technique. So my question
is depend on the size of the pelvis. So it is a little bit subjective assessment by the surgeons.
Thank you very much again. Whether ureter is high insertions or low insertions are usually associated with stenosis at POJ junction. Either muscular hypoplegia or some sort of electric valves are there. So you are not disconnecting the pelvic junction, then how you are making sure that there is no obstruction in pelvic junction?
Yes. So firstly, when we do intraoperative exploration, you see there is the caliper, the diameter of the junction is almost normal. And the second maneuver, the most important maneuver to exclude is that we can insert a large caliber catheter through the junction without any, obstacle. So we decided this is normal. So in our results show that this only the obstruction is caused not intrinsic factor, but obstruction, but kinking, because high insertion not ureter only, not any without any intrinsic obstruction.
So meaning by this, if there is an outer kinking, you just remove the kinking and there is no need of pyeloplasty or some sort of this procedure?
Yes. I think this technique recommended for the cases of POJ obstruction without intrinsic obstruction. Yeah.
Thank you.
Thank you very much. We'll move on to reflux following pediatric renal transplantation. Satoshi Apata.
Nothing to disclose. Basic ureteral reflux or BUR can occur as a complication after renal transplantation. However, its incidence varies in different levels ranging from 3 to 79%. There is a risk of graft failure due to reflux nephropathy or urinary tract infection or UTI after renal transplantation. There is a risk, on the other hand, there is no clear standard for the treatment of BUR after RT, and medical treatment and re-anastomosis of the ureter for transplantation are performed in cases with conditions such as recurrent UTI. Dextranormal hyaluronic acid or DHA, deflux, and subureteric injection therapy is now adopted as a less invasive therapeutic method for BUR. And deflux injection therapy for BUR after RT has been sporadically reported since 1995. And our institution has also introduced deflux injection therapy for BUR after pediatric renal transplantations since 2011. So this study aims to validate the effectiveness of deflux injection therapy for BUR following pediatric renal transplantation based on our single institution experience. During April 28 to March 2022, a retrospective study was conducted using the medical records of pediatric patients who underwent defluxing treatment for VR after renal transplantation in our institution. Deflux injection therapy was performed as follows. The patients received deflux via subureteric transurethral injection with a 3.7 French deflux metal needle and 8 French rigid cystoscope. The site of ureteral anastomosis often located slightly to the right of the anterior wall of the bladder. First, we confirmed the ureteral orifice with the cystoscope, and while looking up the front wall of the bladder and pulling down the forceps port, deflux injection therapy, deflux was injected in the direction from about 3 o'clock to 6 o'clock until the satisfactory crescent-shaped orifice was achieved. This is the result. During the period, 68 pediatric patients underwent renal transplantation and 20 patients subsequently developed VUR. 7 of 22 patients underwent deflux injection therapy to avoid renal dysfunction due to UTI. After deflux injection therapy, VUR was downgraded in 3 cases, and subsequently 2 patients received second deflux injection therapy, and 1 patient underwent submuscular channel reconstruction as the second time, respectively. During the observation period, all 7 patients continued to receive prophylactic medication without any history of recurrent UTI. Also, eGFR have not significantly decreased after deflux injection therapy during observation period. So discussion. Recurrent UTIs associated with VR after RT are reported to affect graft survival and require surgical intervention. Since DHA injection therapy was reported in 1995 as a minimally invasive treatment method for VR after RT, and some report has been published. The response rate was approximately 50%. In this study, all patients had experienced UTIs before deflux injection therapy, and VR was downgraded or disappeared after the first injection therapy in approximately 40% of the patients. And after the second injection therapy in more than 50%. On the other hand, systematic review reported a success rate of 22 to 64%, and it concluded that low success rate was seen in DHA injection therapy, so DHA injection therapy should still be considered in selected cases, such as cases with low-grade reflux with a favorable orifice configuration. So after renal transplantation, ureteral anastomosis is located on the anterior wall of the bladder, so the tip of the cystoscope must be raised, and the forceps ports must be lowered. And the anastomotic site is far from the internal ureteral orifice, making it difficult to stabilize the surgical field. So these factors are considered to be the factor that make the procedure difficult. In this study, it appeared that deflux injection therapy was able to reduce the frequency of UTIs and avoid or postpone more invasive surgical treatment with little effort on the renal function. Thus, deflux injection therapy is considered to have a certain effect. In my conclusion, deflux injection therapy for VR after renal transplantation is technically challenging because the new ureteral orifice is ventrally anastomosed at the bladder. However, our results showed its efficacy in reducing the frequency of UTIs. According it contributed to preservation of the renal function after pediatric renal transplantation. Thank you for your attention. Thank you for your attention.
We have time for one very quick.
Or introducing DFAS in the patient because you have 28 to 2011, you don't have DFAS. What's your approach? What you will do for this kind of patient before DFAS?
Sorry?
Because you introduced DFAS in 2011, right? What happens before?
Before introducing the DFAS injection therapy?
What procedure will you do?
I'm not sure what kind of the procedure they do some procedure. Sorry.
Thank you.
Thank you very much. Well, in view of time, shall we move on? So for the next speaker, please.
Good morning, everyone. Good morning, everyone. I'm Monica representing India, and I'll be discussing about the patients who have undergone de-teethering surgery for a tethered cord syndrome. And we all know that neurogenic bladder is one of the most important is a challenge which we face in the post-operative period for these patients. So the aim of our study is to enumerate the bladder dysfunction in patients of tethered cord syndrome, along with studying the changes in the bladder functions after the de-teethering surgery. So all the patients who were less than 18 years old and had tethered cord syndrome were included in the study, and a complete detailed urodynamic studies were conducted on these patients in the pre-operative period as well as in the post-operative period after 6 months. A complete urological workup was as well done. So we had a total of 26 children with a mean age of 5 years, and the male to female ratio was almost similar, and the most common cause of tethered cord syndrome was lipomeningocele, followed by other causes. And the urological symptoms were found in about 39% of the patients. The motor, sensory and the pain symptoms were as well recorded. Coming to the cystometric findings, our observation was that the detrusor overactivity was present initially in 4 patients, which disappeared in 3 out of these 4 patients. However, to the offset, there were 5 patients who developed new detrusor overactivity. Coming to the maximal cystometric capacity and the detrusor pressure maximum, there wasn't much change in either of the parameters. However, the leak point pressures, they definitely increased in a few patients. The most important parameter which was actually affected was the compliance. The compliance improved in children who underwent surgery before 3 years of age, hence implicating that the surgery for de-teethering should be done before 3 years of age as early as possible. Patients with urological symptoms and without urological symptoms, when they were compared, the ones who had urological symptoms, they showed marked improvement in the maximum cystometric capacity as well as in the compliance. However, patients who did not have urological symptoms, their bladder functions deteriorated in terms of maximal cystometric capacity and the compliance. So overall, we found that the pain was improved in 100% of the patients after de-teethering surgery. The sensory symptoms improved in 50%. However, the motor symptoms improved only in 33% of the patients. The urological improvement was noted in about 69% of the patients in compliance, maximum cystometric capacity, and in the leak detrusor pressures. So to conclude, urodynamic study is the first line of investigation in patients of tethered cord syndrome so as to establish the baseline bladder dynamics, and the de-teethering surgery, it improves the bladder profile in patients who have preoperative urological symptoms, but the offset is that de-teethering can also cause worsening of the bladder functions in few of these children. The best part is that there is improvement in the bladder compliance after de-teethering surgery. Thank you.
Thank you so much for the sharing. Yes, any questions from the floor? Comments? If not, no, just wondering, what's a possible explanation for the deterioration in the asymptomatic group?
That could be, although all the surgeries were done by the neurosurgeon, by one single neurosurgeon. So I cannot say that it was a surgical difference, but it could be because of the lesion. Maybe the lesion was bigger along with the tethered cord. That was the cause of deterioration in these patients, certain group of patients.
So now may I ask you a question? So what you recommend indication of deterring surgery for such a tethered cord cases? So for normal, for asymptom, for urologically asymptomatic patient, should not be indicated. Am I right?
Yeah. So all these patients had symptoms, either they presented with pain or with motor or sensory symptoms. So these were the patients who were actually initially attended by the neurosurgeons, and they took the decision of de-tethering after doing the MRI, spine and the brain, and then they referred these patients to us for the urological follow-ups.
So let's say asymptomatic patient with some lipoma, there is a lipoma, sacrosanguine myolipoma.
Yeah.
With the tethered cord.
Yes. So the maximum number of patients were of lipo-MMC with the tethered cord.
So in the case if there are no symptom, no indication for deterring surgery. Do you mean?
No, they have symptoms. So these patients, the group of patients which we had taken, all of them were symptomatic before the surgery. The urological symptoms were noted only in 39% of the patients. However, the motor, sensory and the pain symptoms were present in the rest of the patients.
So what is your preference? So some lump in sacral region without urologic symptom and do deterring surgery, urologic sequelae?
Yeah.
What is?
Yes, that continues to be the controversy.
Okay.
That as per the literature also, de-tethering is not recommended for all of the patients. With our study also, we still say that de-tethering is not recommended for all the patients.
Thank you. This is a discussion that could go on for a long time. We probably should stop it.
Yes,
thank you very much.
Thank you so much.
Degree of elastography in comparison to dynamic renal nuclear scintigraphy. Arnott Kendrick.
Good morning, everyone. Pelvic junction, as we know, is one of the most important causes of hydronephrosis. In its diagnostic workup, we initially go for ultrasound abdomen. It is an initial imaging modality, but it can only inform about the pelvic system dilatation as well as parenchymal status. It cannot comment upon the function. For assessing function and obstruction, we need nuclear scans. However, there is some risk of exposure while using the nuclear scans. Ultrasound elastography is a new novel technique which enables evaluation of the rate of wave dispersion and thus measures tissue stiffness. There are some recent reports on use of elastography for renal pelvic assessment. We conducted this study to assess if findings by elastography can be correlated with split renal function in dynamic renal nuclear scans. In methods, it was a prospective observation study from October 21 to March 23. We followed stroke guidelines for conducting the study. All hydronephrotic patients were assessed and bilateral hydronephrotic patients were excluded. System was on a grading system. Then elastography and exam were performed. If values of elastography could be obtained, they were tabulated. In case it was not cannot retrieve for some reasons, we taken them as 0, and finally analysis of the values were performed. Elastography was performed by the radiologist with the Phillips affinity system. The main sonographic axis was along the renal pyramidal axis, and we took 3 regions of interest of 5 to 10 mm at the upper, mid and lower pole, and a mean of them was calculated in kilopascal. Radionuclide scan was performed in supine position using 99 technetium ethylene dicysteine scan, and split renal function apart from other measures was calculated. In results, we evaluated total 20 patients. The mean age was 39 months. The male to female ratio was 4:1. We had 2 patients of grade 2, 6 grade 3 and 12 grade 4 hydronephrosis, like in this picture. The mean split renal function of the affected kidney was 26%. The corresponding value of elastography was 4.45 kilopascals. Elastography was not possible in 6 patients. On Spearman's row correlation between the split renal function and elastography, the values were statistically significant, like seen in this picture. With increasing split renal function, the elastography values are increasing. So, in conclusion, elastography may be able to comment upon the renal function status in hydronephrosis. A kidney with good renal function will have a higher elastography value. Even if elastography value reports non-feasible, it may suggest that the function is close to or less than 20%. With further refinements, elastography may be used as non-invasive radiation-free alternative diagnostic modality for renal function evaluation. Thanks for your patient hearing.
Thank you very much. Any questions? So are you going to move to your ultrasonic technique for evaluating your function, or are you going to continue with nuclear medicine studies?
Sir, as of now, it's in the preliminary stage. So, in due course of time, that's what I mentioned in the conclusion. If we can have this and with large number of studies, because as of now, there are only 6 studies which have evaluated split renal function and elastography. 2 of them are for vesicular reflux, and only 2 as of now which have specifically evaluated elastography for hydronephrosis.
Thank you. Do you think you will be able to pick up any scarring, like a VUR associated scarring?
Ma'am, as of now, it would be difficult to comment upon, but as I said, if more people are opting for this modality, we will have further results and we can analyze the results later on.
Thank you. Any other questions?
Thank you.
Thank you very much. So we will proceed with the next presentation, which is on congenital bladder diverticulum in children, clinical radiological profile, and surgical outcome. Thank you.
Good morning, everyone. I am going to present the congenital bladder diverticulum in children, clinical radiological profile and surgical outcome. This paper is from India. The congenital bladder diverticulum is basically protrusion of the bladder mucosa due to detrusor muscle weakness in the absence of bladder outlet obstruction. Its incidence is around 1.7%. Our aim of study is to highlight the spectrum of presentation and management of congenital bladder diverticulum at our center. So, this is a retrospective study. We total 12 patients were taken, and the age group was 6 months to 7 years, and the male to female ratio was 6.1, and all patients were evaluated by history examination, routine blood investigation, imaging like ultrasound, Whiting's cystogram, cystoscopy, renal scan, and if required, urodynamics. And after resuscitation, these patients were subjected for surgery, either diverticulectomy or plus minus ureteric reimplantation depending upon the reflux. So out of 12 patients, 9 patients presented with bladder outlet obstruction in the form of poor urinary stream, staining, dysuria, dribbling and palpable bladder,
and 3 patients present as a recurrent UTI, that is the fever, burning, maturation, pyuria and failure to thrive. Out of 12 patients, the ultrasound was able to detect diverticulum only in 8 patients, with right hydroureter nephrosis in 2 patients, left hydroureter nephrosis in 2 patients, and 3 patients have a bilateral hydroureter nephrosis, while maturating cystohystogram detected diverticulum in all 12 cases, where the right side was 7 and left side was 5, and 3 patients have a ipsilateral vesicular reflux of grade 4-5. So after resuscitation, the diverticulectomy was done in 9 patients, and diverticulectomy with ureteric implantation was done in 3 patients. And in follow-up, the clinical evaluation, kidney functions, ultrasound and renogram, and some patient urodynamic was done at the age of, at the follow-up 3 months, 6 months and 12 months, and patient had no complication and no mortality. This is some of the operative photographs. You can see there is a Hutch diverticula associated with grade 4-5 reflux. So excision of diverticula with ureteric implantation was done. And this is the another patient with a large diverticula without reflux. So diverticulectomy was done. So on conclusion, bladder diverticulum is always suspected child with symptom of bladder outlet obstruction or unexplained UTI. Diagnosis is confirmed by widening cystoscopy and cystoscopy, and early surgical outcome gives better result. Thank you very much for patience.
Thank you very much. Questions?
Thank you for your work.
What, sir?
How's your follow-up?
You can't hear what you are saying.
I mean,
say again, please.
Your follow-up. How's your follow-up?
Posterior urethral valve. It was not secondary due to posterior urethral valve, all interior urethral valve. As in the beginning I told you, it is basically protrusion of mucosa through the bladder without any known pathology of the urethra. So it was a primary bladder diverticulum only. I have not incorporated patient of the secondary diverticulum which is occurred due to the posterior urethral valve.
Thank you.
Go ahead.
Can I clarify? You're talking about Hutch diverticulum?
Yeah.
And what do you do with Hutch diverticulum in asymptomatic patients?
Any diverticulum which is a primary should be removed without waiting that patient will develop renal damage, because it is almost always associated with reflux and obstructive uropathy.
Well, maybe one final question.
Thank you, Mr. Chairperson. Good morning, everyone. So despite standardized guidelines, delay in referral and orchidoidpexy still occurs. So therefore, that is why our aim for our study is to look at what are the factors associated with accuracy and timing of UDT referrals made to our pediatric surgical centers. Our study was conducted across 3 different pediatric surgical centers in Malaysia, 2 in Peninsula and 1 in West Malaysia. So after obtaining ethical approval, new patients referred for UDT were recruited, where parents had to answer an online anonymous questionnaire while the patient is being examined by the pediatric surgeons, and all data was recorded and analyzed with SPSS, and a chi-square was used to compare categorical variables. So these are our results. We had a total of 201 patients, out of which 101 was accurately diagnosed with UDT, making the overall accuracy of referral was 50%. Looking at the data demographically, there was a significant difference between median age of referrals across all 3 centers, and this is reflective of the median age at review. Our highest referral numbers came from community clinics, followed by pediatric clinic, in-hospital referrals, and also general practitioners, GP. GP also had the highest accuracy of referral at 64%. When determining the factors affecting accuracy of UDT diagnosis, we found that UDT was more accurately diagnosed in those less than 1 year old, unilateral UDT, UDT was better picked up in those with impalpable UDT and also those who had a history of UDT mentioned at birth. Prematurity, however, was not associated with higher accuracy of UDT diagnosis. So what stands out about our study is that this is the first local regional prospective study that captures referral pattern and data regarding UDT with patients of varying socioeconomical and geographical background. Our limitations include that the study was conducted during a transition and recovery phase of COVID-19, so there was a backlog of patients waiting for clinic appointments. This could have affected our results, and also we had a small sample size, so a follow-up study may yield a more significant outcome. So we would like to recommend that there's an increased need for an awareness for early surgical referral for timely intervention, and local policies implemented needs to be sensitive to the needs of the local populations. Thank you.
Everybody gets an ultrasound, and then ultrasound is usually done by a sonographer, and then the GP refers. So the pickup is actually much lower, like the ultrasound. So we have that problem where patient gets an ultrasound and then gets referred to pediatric surgeons.
Thank you for your. But however, in our data, it's not reflected in my presentation, we do have patients who did an ultrasound before they were referred to us, but the accuracy is not significant as well.
Thank you very much. Any other questions? Thank you for that. The person that was meant to be presenting the last two papers actually hasn't turned up, let alone noted their presentation, so that's the end of the session. Thank you very much for everyone who has kept the time, and also for the very interesting questions. Thank you.
I would like to invite Professor Song Chun for the first presentation. He will call it substitute for esophageal replacement in children with lung segment stricture.
Good morning, ladies and gentlemen. I come from Children's Hospital of Fudan University, Shanghai, China. The topic of my presentation is ileocolic substitute for esophageal replacement in children with lung segment stricture caused by acoustic injury. With the usage of child-proof container, failure acoustic injury to the esophagus are seen in developed countries, but it's still common in undeveloped countries that are undergoing industrialization. In severe cases, four-thickness injury to a lung segment resulting in an intractable stricture that can fail to respond to dilation. Endoscopic dilation is the recommended primary therapy, but continuing with dilation at frequency intervals for longer than 6 to 12 months is usually unproductive. So it doesn't work. Esophageal stenting can be helpful as definite therapy, but its precious role remains undefined. Given the long-term risk of malignancy, children with severe esophageal injury should be considered for resection and replacement. Esophageal replacement is the ultimate treatment, but there is lack of consensus in the operative technique. So the objective of this study was to summarize the single-center experience of ileocolin replacement in the treatment of lung segment esophageal stricture caused by acoustic injury in children. The hospitalization and follow-up data of children with lung segment acoustic esophageal stricture in Children's Hospital of Fudan University in the past 5 years were collected and investigated. So this is the procedure. The native esophagus was resected by thoracoscopy surgery. Then the vessel of the right colon and the terminal ileum were isolated. The proposed segment of bowel and vessels were blocked by clamp to verify adequate circulation. The middle colic artery was preserved. The graft usually includes 5 to 15 centimeter ileum and the right colon. If the blood supply to the graft is good, the vessel and bowel was cut off at the blocked site. The terminal ileum was pulled to the neck through a retrosternal tunnel to anastomose with the cervical esophagus. Then the transverse colon was anastomosed with the stomach. Ileocolic anastomosis was performed to restore the continuity of digestive tract. In addition, pyloroplasty was performed to prevent gastroesophageal reflux. A total of 21 patients were hospitalized due to the acoustic stricture between 2017 and 2022. 9 of them, including 5 boys and 4 girls, underwent ileocolic replacement of esophagus. The stricture segment were longer than 5 centimeters in all patients, and all the patients underwent 4 to 15 times of dilation, except for 2 patients who failed to dilate. The corrosive substance include oxys in 8 patients and acid in 1 patient. The age at esophageal replacement ranged from 2 to 14 years old. The intervals from injury to surgery was 4.5 to 37 months. The operation time was 4.5 to 9.5 hours. The negative esophagus was resected in 8 patients through a thoracoscopic surgery, and 1 retained the native esophagus because of severe adhesion. The average post-operative ICU stay was 6.2 days. And the enteral nutrition was started on 5.2 days. And oral feeding was started on 13 days after surgery. Four patients suffered with pneumonia thorax and gastroplegia neck abscess, wound infection, thorax occurred in one each. The picture on the right side the picture on the right side, one of our patients, the esophageal contrast before and after the surgery. These patients were followed up for 5 months to 4 years. 3 patients developed cervical anastomosis stenosis, which was cured by 2 and 3 times of dilation, and a reduced anastomosis in 1 patient. 2 cases underwent reoperative for adhesive ileus 1 and 4 months after surgery. The retained esophagus was resected 22 months after surgery due to encapsulated effusion compressing the trachea. Until the last follow-up, all the patients tolerated oral feeding. The conclusion of this study is ileocolic esophageal replacement can be used in the treatment of lung segment esophageal acoustic stricture, as they are necessary to improve the surgical technique to reduce the post-operative complications. Thank you.
Paper is open for questions.
as well. Can you tell us why and also how much helium did you use? How many centimeters of helium?
It's 5 the blood supply.
And why did you choose to use the helium as well? Most people just use the colon.
Because we think the helium colic replacement can prevent reflux and bad smelling after post-operatively.
I think that's a good idea for you, but a suggestion for you, you'll need to follow these patients for a long time. I inherited a patient 12 years after he'd had a colon replacement. His colon went all the way up to the right thoracic margin, back up the diaphragm and then down to the stomach. I think the colon has a different growth potential than the vertical thorax.
Thank you very much. Thank you.
Thank you.
Thank you, Chairman. Ladies and gentlemen. Unfortunately, my colleague couldn't make it to come to the Paps meeting, so I'm gonna present this paper on behalf of him. So I have nothing to disclose. So, congenital central hyperventilation syndrome is a rare neurological disorder which is characterized by inadequate breathing during sleep. So, which requires a lifelong ventilator support and a tracheostomy. So, otherwise, it's going to be life-threatening. And so it is reported that PHOX2B gene mutation is related to the pathogenesis of this disease, and 20% of the patients is associated with the heart-spring disease. It is a progressive disease, so when it becomes very severe, so it can affect their breathing even while patients are awake. So this is a very difficult disease to treat. And the diaphragm pacing has been developed as an alternative to invasive respiratory support, and it has been approved by Japanese public healthcare system in 2019 for treatment of CCHS. So I'm going to present our experience of the first 5 cases of the diaphragm pacing for CCHS patients. So we have been treated CCHS patients by diaphragm pacing, and so most of the cases were adults who were dependent on their respiratory support even while they are awake. And the last case was a 10-year-old boy who is our first case for pediatric patients. And then 2 of 5 cases has a history of their procedure for heart-spring disease. So I'm going to show you the video of the procedure. So our first thing you do is mapping, so which is a procedure to identify the location where diaphragm makes a maximum contraction by test simulation. And according to the mapping site, so you insert the electrodes, two electrodes on each side of the diaphragm. So by using this special device. So this device can store the electrodes in the big needle, and you can control the angle of the needle. So you need to be very careful not to perforate the diaphragm. So you need to insert the needle tangentially to the diaphragm. So 2 electrodes are inserted now. And after insertion of the electrodes, you confirm the contraction of the diaphragm by external stimulation, so you get a very good contraction now here. So 4 electrodes are inserted. So after insertion of the electrodes, 4 electrodes are exteriorized through the epigastric port site and tunneled to the upper abdomen. And so so set there are 4 electrodes through the upper abdomen, so you can connect the portable stimulator which can support the patient's respiratory. So after insertion, install the diaphragm pacing, so SpO2 of the patient is significantly improved after insertion. And transcutaneous carbon dioxide pressure, so which was higher than 40 millimeter mercury in all the patients, has significantly improved after insertion of the installation of the diaphragm pacing. So diaphragm pacing dramatically improved the clinical status and alleviated pulmonary hypertension, and so significantly improved the patient's quality of life of CCH patients. Thank you very much.
The floor is open.
Hashime from Japan. Very interesting. Thank you very much. Uranium battery.
Yeah.
So how long?
It's quite long, and stimulator in the pocket.
Mm-hmm.
And then, yeah.
So you have a check system whether the battery will work longer or shorter?
Yes.
Thank you.
Thank you for the question.
Thanks for presenting this. It's a beautiful video. So this diaphragmatic pacing, and usually it's a neurologist working with the respirologist who make a decision on what is the best format. Because we often do EMG to the diaphragm to see what the diaphragmatic muscle is like. So do you use this for all of the patients, or do you also have some type of selection mechanism on who gets what?
Yeah, actually, so we have a collaborative support of the specialists of the respiratory support. So we make a discussion with this team to selection of the patients. So actually, we've never done the phrenic nerve stimulation. So in future, so we have to discuss about that. So at the moment, we only do the diaphragmatic pacing. Thank you very much.
Have you used this technique on kids with Guillain-Barré syndrome, kids with bilateral diaphragmatic palsy? Have you used them?
Yes, so that's a good point. So at the moment, so this procedure is allowed to do only for CCH patients. So at the moment, but then in future, so it's going to be a very good indication for this procedure.
But Rod, if you have diaphragmatic denervation, it won't work.
All right.
Because when the diaphragm loses denervation, also loses tone. You have to have some type of denervation of the diaphragm, even if the nerve is not working.
Right.
Yeah, phrenic nerves should be intact to do this procedure.
Thank you. Discussion?
Thank you very much.
I'm Yutaro Maeda from Japan. I'd like to introduce about computational fluid dynamics. No COI to declare. Congenital tracheal stenosis is a rare and often life-threatening anatomical anomaly characterized by complete tracheal ring. Slide tracheoplasty is currently the gold standard surgical treatment for severe CVS. Although slide tracheoplasty can significantly improve respiratory distress in many cases, post-operative symptoms of airway obstruction sometimes remain. Computational fluid dynamics can be used as a novel objective assessment tool for CVS. This technology is familiar in field of engineering, like fluid flow around the curve. The present study aimed to evaluate the efficacy of slide tracheoplasty by digitizing and visualizing airflow characteristics using CFD pre- and post-operatively. I'll introduce 3 steps of analysis. First, 3-dimensional virtual models were created from CT data. Second, to smooth the 3D models. Third, using CFD software to analyze airflow. Method: 8 patients were enrolled. 88 CPS cases underwent slide tracheoplasty at the study center in these 20 years. Patients with endotracheal intubation at the time, they underwent computed tomography, and those with abnormal tracheal avulsion like tracheal bronchus or left pulmonary artery sling were excluded. Three-dimensional models were created using preoperative and postoperative CT data. Then, airway resistance and maximal airflow velocities were assessed using CFD under stationary inspiratory flow 10 ml per kilogram per second. Airway resistance and velocity were clearly visualized in the 3D tracheal models using several different colors. We calculated improvement rate by dividing the postoperative value by the preoperative value. This is whole data. Case numbers are sorted by improvement rate. Preoperative classification referred to Anton Pacheco's classification by symptoms. 2 mild cases are asymptomatic. Stenosis are accidentally found when cardiac or bowel surgery undergone. 3 cases hospitalized by respiratory symptoms, which are moderate cases. 3 intubated cases are severe cases. In all cases, diameter of trachea are extended, and in 6 cases, airway resistance are improved. In 6 cases, the graph is extended. 4 cases with better rate of resistance and velocity, symptom got better. Case 8 with a short tracheal stenosis showed no improvement in resistance and velocity. These are 4 cases. The present study demonstrated the efficacy of CFD assessment before and after slide tracheoplasty in patients with CDS. Since the subjects were limited to patients with a simple anatomy, studies with patients with various complications are warranted. Thank you for your attention.
Everybody's open for questions. You had a mortality, and I was not able to see. There was some parentheses after that, but I can't see it.
Thank you, Chairman. Following the previous presentation, I will share our experience of the slide tracheoplasty for congenital tracheal stenosis, CTS. Nothing to disclose. The slide tracheoplasty is the gold standard surgical procedure for the CTS. We have performed about 100 cases, and the outcome was acceptable with very few post-operative surgical intervention. The steps: first, expose the trachea and estimate the stenotic lesion and transect the trachea, and inside the back side of the upper trachea and the front side of the lower trachea, and slide them and suture and tie. I'm going to show some tips. First, for the long segment CTS, we do the laryngeal release, which is we dissect the center part of the hyoid bone and the muscle, and then we obtain the good mobility of the upper trachea. And for design, inserting the small needle from outside the trachea under the bronchoscopy and check the length and make the point of the transaction the ratio 3 and 2. That's important. It's not in the middle of the stenotic lesion. And if the stenosis beyond the carina, we do the inverted Y-shaped incision like this scheme. And after the plasty, we will have the wider inside like this picture. And the minimal dissection of the trachea is very important in this procedure. You can dissect circumferentially only at the point of the transaction. And after transaction, we do the dissection posterior wall of the trachea, putting the stay suture both sides and look just behind the trachea, but that's it, and inside the trachea. To preserve the connective tissue around the trachea is very, very important to preserve the blood supply. And suturing, we start with the top of the anastomosis like this, and second, third, fourth like this, but not tie yet. And suture stitch will be applied from top of the bottom, but tying should be performed from bottom to top. And after that, we put additional stitch, and that's it. I'm going to show some pitfalls. A case with a tracheal bronchus like this scheme. It's not a good idea to incise just behind the upper trachea. Because of the tracheal bronchus, it is more difficult to open the trachea nicely. So you should incise a little bit laterally. And a different case with a very, very long segment stenosis, we fixed all stenotic area, but we see the atelectasis after the surgery. Why? The possible mechanism is because the left main bronchus was deviated upwards after the slice, and it may conflict with the left pulmonary arteries. That may happen in this kind of very long case. And three-dimensional tracheal models are useful to compare the different designs by simulated surgery and check the conflict between the blood vessel and the bronchus like this, and CFD as well. In conclusion, the precise design and consistent maneuvers are important, and minimal dissection for preserving blood supply is very good, very important. And three-dimensional models are useful for the simulated surgery. Thank you for your attention.
Thank you. Very beautiful presentation technique. Hirumi?
Thank you for of the tracheal stenosis. We need to dissect wider, more long lesion. So, how to minimize the dissection?
So for the longer segment of stenosis, we do similar question. We don't incise the connective tissue around the trachea. That's very important. If it is very difficult to see the top lesion, we dissect a little bit the connective tissue, but not close to the trachea, but the side.
Why?
Yes. That's important to maintain the blood supply
around Turkey. Thank you.
Thank you.
Thank you very much. Thank you.
How can we do practice repair safer, easier, and better? My solution has been a neo-practice surgery, which is a crane-powered entire chest wall remodeling. So you see the depiction for the technique here. First of all, we put the sternal screw to elevate the sternum all the way up, and then the pectoralis bars are introduced below the sternum already lifted very high, so it's a quite an easy, straightforward technique. And then all three bars are connected together with a single breech plate with the bolts and nuts. So this is the multiple bar entire chest wall remodeling. So key elements of the neo-practice surgery is crane-powered lifting. Therefore, we need no pectoralis bar push-up to the chest wall, entire chest wall remodeling and sandwich technique, and the multiple bar approach and the breech stabilization. Recently, we did over 600 cases with the excavatum catenatum and the complex cases. The age was 12. Crane technique to develop space and reduce the pressure from chest wall and enhance the visualization. So we developed the screw cranes into the sternum everywhere whenever you need. And the second version was corkscrew type, so we can drive in the corkscrew and lift the chest wall. Entire chest wall remodeling is not a partial repair. Just try to remodel whole entire chest wall. So we need multiple bars because we have insufficiency to cover with a single bar or parallel bar, crossbar, and ultimately we need XI bar for entire chest wall remodeling. Those are parallel bars, crossbars, and XI bars. The bridge is to make the bar unrotatable. So we connect the two bars with the single bridge. We can do with the parallel bars, the crossbars, and the XI bars. We stopped using the single bar approach since 2021, and we do multiple bar techniques, the parallel bars, the crossbars, and the XI bars. So overall complication was 16%, but all were minor ones, and we didn't see any major issues. And notably, we don't have any bar displacement. Minor complications were pneumothorax, effusion, and wound infection. In conclusion, the crane-powered entire chest wall remodeling is a very effective method to remodel the chest wall, and we have no more bar displacement or insufficient repair. Therefore, we get the aesthetically and functionally better outcomes and hopefully achieve anatomically normal chest wall. Thank you very much.
Go ahead. Thank you for the talk. 3 questions. How do you make a decision? Do you use any fixation in addition to the bridge? Do you use any fiber wires? The third question is, when you do the screw on the sternum, how can you make sure you're not injuring the heart?
Okay, thank you. Very good points. First of all, what was the first one? The symmetric, asymmetric, the variety of deformity, and you can try just crossbar, parallel bars, and then finally you can decide that you can pick something must be the best for the case. And the techniques have their own inadequacies, so you have to think about that, and then you can choose the best one for the specific patient. And I don't use any sutures, just the breaching, that's all. And your final question was? What was
the sternum, the screw for the sternum?
Yeah. We measure the thickness of the sternum before we do, and then we decide the length of the screws.
Thank you very much.
Of cases. Do you have a centralized service in your country? In other words, are you the only center or maybe one of the two centers where all the practice get done? If that is the case, I think the rest of the world needs to follow you. Thank you.
Thank you. I'm not the only center, but I do.
For this and also for all the contributions you've made to infective surgery and for education. People should know that you've spent a lot of time educating others online and in other ways, so thank you for all of those contributions. My question is, what percentage of your patients, and I completely agree that many patients who are happy still have an incomplete repair. I completely agree with that. But what percentage of your patients are getting more than one bar? And when you show these diagrams of 3 bars, it seems like the incision would have to be pretty long to put that long fixture and also almost impinging on the axilla. So does the incision end up being a really long lateral incision, and do any patients feel discomfort because the bar is close to the axilla? And also, just how many patients actually use
just one bar? 2 bars, and I don't use any more single bar approach because it's not sufficient. So I don't want to do anything insufficient. So over 3 years, 2 years, 3 years, I abandoned the single bar approach, and I can get better results. And what was your final question?
Well, when you use 3 bars, it looks like on the diagram that you have a very long piece of metal fixing. So does that mean you make a very long lateral incision to get that in? Or
we can pass subcutaneous under the skin, so we can push it in, and we have small incisions on the upper and lower, so we can do that. Yeah.
Quick one, Don.
Don Morris from London. Thank you. On the video, it looked like the bar is entirely intrathoracic. Can you comment about getting the bars out when the sufficient time has passed? How easy is it to do that?
About removal.
When you get rid of the bar?
Yeah, it's when you stay with the one bar. Recently, I put the crane on in every body mover cases, which makes better and safer for the body movers. So we don't have any problem with the body movers.
Thank you, sir. Great. It's great. Thank you. I think your crane is phenomenal. Don says that in our age, we always have to use a crane. So thank you very much. And the other question that I have is, I saw that your age range was very wide, including a 3-year-old, starting at 3 years old. Do you usually do kids younger than 10 years old?
Basically, I don't have any age limit, so probably we can do after 3-4 years. Those patients are big enough to do, and my oldest one was about 55 or something. So basically, I don't have any limitations. They're all the same, and younger patients are much better to do. Yeah, much easier to do.
Thank you very much.
Thank you.
Parent-reported health-related quality of life outcomes and impact on family of congenital diaphragmatic hernia survivors after repair. So CDH survivors often experience long-term CDH-associated morbidities, including musculoskeletal, gastrointestinal, and respiratory issues. And there are a few studies on the impact of health issues on health-related quality of life, and all, as far as we know, are from developed countries. So the aim of our study was to evaluate parent-reported health-related quality of life outcomes and the impact on the family of CDH survivors after repair compared to parent-reported health-related quality of life of age-matched and sex-matched controls. So we contacted parents or primary caregivers who were eligible, and inclusion criteria were those parents and primary caregivers of CDH patients who were still alive at the time the study was conducted and who were aged between 3 to 12 years old. We compared them to age-matched and sex-matched controls, and our exclusion criteria were those who were not fluent in either English or Malay language, and those who had primary surgery elsewhere. We conducted the following questionnaires using the PedsQL Quality of Life Inventory, the Generic Core Scales 4.0, and the Family Impact Module 2.0. Just an introduction to these questionnaires. So the 23-item PedsQL Generic Core Scales were designed to measure the core dimensions of health as delineated by WHO, including physical, emotional, and social functioning, as well as role, or in our
children, of course, school functioning. And the PEDS-QL family impact module was designed to measure the impact of pediatric chronic health conditions on parents and the family. And this measures parents' self-reported physical, emotional, social, and cognitive function, communication, and worry. Importantly, in our context, is that both of these are available in both English and Malay, which are the most commonly used languages in Malaysia, which is a multi-ethnic and multi-language society. So we had 45 CDH patients and 45 age-matched and sex-matched controls. The age of the participants, median age was 6 years, ranging from 3 to 12, and a fairly equal proportion of both sexes. When we looked at the generic core scales, what we found was that CDH patients had worse reported overall and psychosocial health scores compared to controls. But interestingly, when we looked at the family impact module, we found no significant differences between the groups in all family impact scores. The limitations of our study include that we did not include some demographic data on family background and socioeconomic status, which could affect parental perspectives and emotional reactions to their child's illness. We had a 59% contact rate for participants, which is not bad, but it could be better. And this obviously was a bias towards survivors because we only interviewed those who had surviving children. And we relied on subjective criteria. It's basically parent or caregiver reported outcomes to provide information on symptoms and current medical conditions. However, we do believe our study has strength. This is the first study on parent-reported health-related quality of life outcomes and impact of CDH repair on family function in a developing country, with other studies describing populations in high-income countries. Our study sample size is among the largest compared to others in the literature on quality of life in CDH survivors. And we have a good case capture. Our center maintains a prospective registry on these patients, and we are a referral center taking patients from all over the country. So we believe that we have a good case capture. In conclusion, family impact of the disease is favorable despite CDH survivors exhibiting poorer parent-reported health-related quality of life compared to controls, and overall parent-reported quality of life is poorer than survivors. And future studies could expand the cohort of study participants to a multi-institutional study nationwide. Thank you.
Thank you for excellent presentation. Found very significant treatment programs for like aversion to oral feeding. So did you find anything like that?
Sorry, could you repeat your question again?
Did you find any feeding programs? So programs for oral feeding or something?
Feeding problems?
Feeding programs. For eating.
For eating. Those clinical symptoms. This was purely just health-related quality of life, answering these questionnaires, and that's what we would expand our study to include all these other details as well. So, yeah.
Hello, Carol Wong from Hong Kong. I'd just like to ask, did you correlate the quality of life of your patients to the clinical symptoms, or did you further substratify the patients into different types of CDH?
Yeah, great question. Yes, so that's what we wanted to expand it to. So first of all, I think it's the type of the CDH. But obviously, because we were only interviewing patients or survivors, we would have a very low survival rate for, say, the diaphragmatic agenesis type of patient. So this would be biased towards type A, type B, and some type C. Clinical symptom-wise, so this was a study that was conducted over the telephone by one of my trainees. So we could not gather very detailed data on the clinical symptoms. So we could match it to what was available in the records, but that would have been a retrospective review rather than this, which is a prospective study.
I see you have a prospective database, so probably the future direction would be really correlate this clinical symptoms.
Yeah, absolutely. Thank you.
I've got one last question for you.
Yeah.
Obviously, these patients are controlled.
Oh, that's a fraught question in our society. So we just in and of itself, so we don't know.
Thank you very much.
Thank you.
The final presentation of this fantastic Paps meeting. So I'm switched to Sylvia from Tokyo. I have nothing to disclose. So, thoracoscopic lobectomy is an established procedure for congenital malformation, congenital lung malformation for patients, pediatrics. And sometimes the difficulty exists. For example, incomplete fissure and preoperative infection that causes lymphadenopathy and adhesion in the chest cavity. So recently we published a paper in JPS Open which shows the prevalence of the incomplete fissure in the pediatric patients with CPAM, and which presented so higher prevalence in the upper part of the loss of the incomplete fissure. So we developed a fissure-less lobectomy for incomplete fissures, so which includes division and the separation of the pulmonary arteries and veins and bronchi, so prior to the division of the lung parenchyma. So it is very advantageous in reducing the postoperative air leakage. So after separation of the each structures, we cut the parenchyma by using a sealing device. So this study is aimed to evaluate the impact of complete fissure and preoperative pneumonia on operative outcomes of thoracoscopic lobectomy in children. So 65 consecutive cases are included and evaluated. So in comparison with the conventional lobectomy and fissure-less lobectomy, so we've done 7 cases of fissure-less lobectomy. And there is no significant difference in terms of operative times and duration of chest tube drainage between the two techniques. And so regarding operative lung infection, so there is not also a significant difference in operative times and duration of chest tube drainage. But if you look into the locations, left lower lobectomy after the history of the preoperative lung infection result in longer duration of chest tube drainage. So severe incomplete fissure and preoperative pneumonia cases were treated effectively and safely by thoracoscopic lobectomy. And the fissure-less lobectomy technique was effective to treat the incomplete fissure, so without compromising the surgical outcomes. And the preoperative pneumonia may affect postoperative drainage only in left lower lobectomy. Thank you for your attention. I'm happy to take any question.
Thank you for the question. The longer...
Yes, big question. So aortic, and so in this case, it has so amount of drainage was a drain tube longer.
Based on your experience, have you learned any technique to make it to make the fissure easier during the operation?
Sorry, I didn't get your question.
Are there any techniques that you could use to separate the fissure?
Separate the fissure. So this is why we introduced the fissure lobectomy technique. So by using this, so you don't dissect the lung parenchyma. Before cutting the each structure, so you don't touch the lung parenchyma. So if you cut the lung parenchyma, so it causes air leakage after operation. So that is why we developed this technique.
I think fissure-less with the fissure lobes is still, and I think it's the most important thing. Any questions? That's the end of this session, the last session of this Paps meeting. I hope to see you guys in Hong Kong next year. One last thing to do to the meeting. The next sort of session is 11:30, so I've got 8 minutes of toilet break or coffee break.
Thank you very much to all of those people that are out in the back there that have worked their butt off for the whole conference to make this run smoothly. We often don't thank those people enough. There's the guys out the back that we can't thank because they can't hear us. But can you please pass on to the people out the back that we're very grateful.
Flag for the next Paps meeting is Lee Carlo in the room. If not, we will have a surrogate to do that. We give it to the past president, immediate past president, and current president of Paps.
May you request it at
All right, good luck for next safety.
Thanks very much.
You promised me 100. 100.
All right, great job. Thank you very much.